Dr. Ivo Boškoski, thank you so much for joining me on this conversation. You're speaking from Rome today, Italy, and I wanted to start by welcoming you first.
Thank you.
How is the COVID situation in your area right now?
Well, my area here is the Lazio region. Italy is divided into regions.
Mm-hmm.
And Lazio region is a red zone. So I am in the red zone right now. And the hospital where I work is the biggest hospital in the region. And I can say in Italy is the biggest oncologic pole. And right now we are facing a dramatic situation from several points of views. The first one is that we are crowded. All the patients are coming here. There are several hospitals in Rome and in the region, but we are mostly hit by the crisis. And the second is that many doctors and nurses are COVID positive. Some of them are in a critical situation. And every day there are different departments that are closed. So for instance, today I was supposed to meet a guy from urology to work on a staminal cells project. He just sent me a message saying that he's in a quarantine, that he's positive. And that's it. We cannot meet. So he can't even talk because he's coughing all the time.
Mm-hmm.
So this is unprecedented times and unprecedented situations. We do not know how this will evolve. We can expect the peak of this situation in mid-December, if not earlier. We are facing a dramatic situation now, but the drama is still to come. From an endoscopy point of view, I can say that now we are doing endoscopies to people that strictly need it, to bleedings, to cancers, and situations that cannot be postponed. And what we are postponing is fecal occult blood positive testings. You have Cologuard in the USA. We do not have it here. But if somebody has indication to colonoscopy right now, it is not the case. So all these people, we got their colonoscopy in probably in 6 months. And for most of them, it will be too late, mm-hmm. I'm afraid. So the number of deaths is not directly only correlated to COVID, but to what it will provoke on the sectors. So from one point of view, it is an unprecedented economic crisis. From the other point of view, it is unprecedented humanitarian crisis with all this suffering. And at the end, it will hit also the future of everybody from a surveillance point, from follow-ups. A second very important point is that every hospital or almost is dealing with car accidents, with routine surgeries, with appendicitis, cholecystectomy, oncological patients. If we consider urgent surgeries and urgent medicine for people seeing diabetic ketosis, people that need urgent care, this is the point. So, and even if if today now somebody will came in the hospital with a heart attack, there is high chance that cannot be seen immediately because there is somebody that is not breathing due to COVID. Okay, so this is the drama of this situation. Simply, we do not have enough resources. We are in the richest country in Europe, in the richest continent. We have medical treatments that are of avant-garde, any kind of oncology treatments, drugs of the future, and so on. But we can't deal with a situation that is a pandemic, infectious disease, that from one point of view is really simple. It's an infection. You need to do a prevention You don't need to do complex surgeries. You don't need complex drugs. You need prevention. You need to wash your hands, wear a mask, don't meet people, and so on. This is the cheapest and easiest way of prevention. But still, we have a high impact on the society, on the hospitals, and everything.
In the GI department itself, what kind of volume are you seeing now compared to last year same time, one, and
So,
compared to the first wave,
yeah.
when COVID began?
So the center where I work is a digestive endoscopy center. Is one of the biggest centers in the world, with a net endoscopy volume of 23 to 25,000 endoscopies per year. We do 1,300 ERCP procedures. We do 3 to 4,000 endoscopic ultrasound procedures, and the rest is colonoscopies, gastroscopies, and polyp resections, complex ESD, let's say, and so on, bariatric endoscopy, and all that. So if we compare that numbers to March, it's our calculations is of 92% of loss of volume only for March and April. Mm-hmm. Then in May, June, July, we had the rise of the cases. And now we are again in a decrease, not like in March, because we are doing also routine cases, but those have been decreased for 20% overall. So compared to last year, we are around 60%. And this is only for gastroscopy and colonoscopy, because ERCP is done for people that really need it, cholangitis, cancer, and so on. And there is no diagnostic ERCP. Operative is operative, and it doesn't have an impact. We also publish this in different papers. The impact is important, especially from economic point of view, because the revenue from what endoscopy gives is not the same from the last year. And from the other hand, we have costs. We have costs on training, on donning and doffing. We have costs of personal protective equipment. We have costs of disposal of the personal protective equipment. And we have costs of people that can't work, stay at home because they're in quarantine, infected, and it's a disaster.
And you're expecting the situation to peak now in mid-November onwards, towards leading up to.
Yeah.
And how are you preparing from a GI department standpoint? In case it peaks.
We are prepared. We have all the time been prepared since March. So now we are doing procedures with 2 masks. One is the N95, and over that we have the surgical mask, because we are in a strict contact with the patients. And we have a program for outpatients and inpatients, and it is different. We screen for the outpatients. There is dedicated personnel. Also, this is a cost. That is phone calling the patients at home, making an interview if they have been in a contact with somebody, if they have symptoms, and so on. Then they come in the hospital, and there are 3 separate zones. In the first zone, they got again the interview. Let's say today the patient has a gastroscopy or colonoscopy or whatever, and they got the interview. Then we do a rapid testing. Now we have also RNA rapid test, and they wait 15 to 30 minutes for this. And if it is negative, then they go to endoscopy. They come in the suite, and endoscopy is performed. And for the inpatients, they go to the RNA-based testing for the virus, for the SARS-CoV-2. Then they get hospitalized. And if the procedure if there is a procedure that should be done, let's say 2 days after the initial testing, they got another test just before the procedure in order to be sure that they're not positive. We have more than 50 operating theaters for surgery, Now we have 8 endoscopy theaters and many other rooms for procedures. This is a very big hospital. We have 1,800 beds. And we have 3 dedicating operative theaters for COVID positive patients, because if somebody has a COVID and needs urgent appendicectomy, you do it. Mm-hmm. Urgent gastroscopy, we do it. So procedures are done all the time. And if we do not know if the patient is positive or negative, we treat those patients as positive with all the equipment. And this is costs.
Yeah, and so coming to the cost, how are you managing the economics? Like, because your budgets have increased, and I'm sure what the department earns would have dropped. So from that standpoint, how are you planning and managing that, especially in light of what is going to come? We've seen one or more waves, depending on how you count a wave until now. But from this point on, expecting the situation to peak again. How are you managing the economics of the situation? And again,
so,
I'm drawing it to GI in particular.
In March, we were suffering the lack of PPEs, personal protective equipment, and also we came with a publication in gastrointestinal endoscopy on methods and ways to reuse respirators and so on. Fortunately, today this is not the case, because our hospital made reserves of all the PPEs, and this is an important cost. This is a private entity that gets money from the region, and the region of the Lazio region, and we still haven't been paid for this. So the hospital is going with its own funds. How do we manage it? We simply treat cases, we give the maximum of the care to everybody, and we'll see what will happen. The management is in be aware of not wasting unnecessary PPEs, and everybody knows that it should not be wasted. We are very sensitized on that, and from time to time we go for another trainings in donning and doffing, because many colleagues have been infecting, especially during doffing and during removing of all the equipment, because if you remove it in the improper way, it is the moment that you get infected. Yes.
Yeah, it is a pretty serious situation. I wish you all the best, doctor. So I wanted to spend a moment and ask you, switch gears a little bit and ask you about, in the light of the future of GI, on what your thoughts are. Now, again, thank you for reading the book Scope Forward. So I'm curious to know what you think applies in a European context, and what do you see as the future from your lens?
So, it is a very exciting time to be in the interventional gastroenterology world, also in the diagnostic, because there are many new things coming from devices point of view, from artificial intelligence and deep learning and so on. So still nobody imagined to write a book like that here in Europe, and this is something that we need right now. So I read it really with pleasure, and it's like the missing ring between what we have and what we're doing. But when you're reading it in a book of thoughts that somebody already elaborated, it's very useful for interventional endoscopies like me dealing with new technology. So that's it. My world is new technology, applying new things to what I'm doing and so on. Also the team where I work. So I really appreciate your efforts, and I simply loved it. It's what we needed right now, especially in this. We need to look forward. Not only to scope forward, we need to look forward. Scoping forward is very important, but looking forward to the future. This crisis will pass sooner or later, and we need to be ready when we will be there.
Thank you. Yeah. Thank you, Dr. Boškoski. Is there anything else that you wanted to share before we close?
We should translate the book in Italian.
Yeah, I should. I should find somebody to do that. Yes, but yes, yeah. Thank you.